Hello friends, in the previous video we have discussed about the pathophysiology, classification and severity of shock, the management of which will be discussed in the current. So for any shock, whether you need to identify what is the cause, and in the meantime you need to immediately start resuscitating that patient, because we already discussed about the timeline. Because prolong the periods of ischemia, if you delay the resuscitation, patient will go in for irreversible damage, or it can undergo reperfusion injury, or it can have multiple organ failure and finally death. So to prevent that, both the diagnosis and resuscitation should always go hand in hand. And as part of initial resuscitation, airway, breathing and circulation should be restored. And you need to address the hypovolemia and inadequate preload. So any patient in shock, patient will be having tachycardia and hypotension, or hypotension in the late stages. So when you don't know what is the cause, you find out the common causes like hemorrhage or any third space fluid loss or decreased intravascular volume due to severe vomiting, diarrhea, or any bowel obstruction, etc., burns, trauma. All these can cause hypovolemic or hemorrhagic shock, or cardiogenic shock, wherein the JVP will be raised. The common clinical examination will help us to identify what kind of shock that the patient belongs to, and based on that the treatment will be initiated. For hypovolemic and hemorrhagic shock, you need to always start with crystalloids, that is fluid administration, to improve the intravascular volume. Whereas in a hemorrhagic shock, you need to have a bit of caution, because when the patient is bleeding, when you know the patient is bleeding, patient has went into shock by means of hypotension. By transfusing that patient with large amounts of IV fluids, you will increase the blood pressure, and thereby you will cause hypertension and cause rebleeding more. So in a hemorrhagic shock, you always control the bleeding by any means, even if surgery is necessary. In such case, resuscitation and surgical control of the bleeding should go in parallel, right? So you address hypovolemia how with the help of IV fluids, that is intravenous fluid. The common intravenous fluids available are called crystalloids. Crystalloids are nothing but normal saline, Ringer lactate, DNS, 5% dextrose. These are the commonly available crystalloids. DNS and 5% dextrose are not used because they are hypotonic. That means their tonicity is less than the plasma. So they will cause more amount of edema. So the ideal resuscitation fluid of choice is going to be the normal saline as and Ringer lactate. And there is no chance for colloids. Colloids, what will happen? They have increased osmotic or oncotic pressure. Whenever there is a period of ischemia, acidosis, etc., the vascular endothelium will be leaky. So whatever the colloids you give, it will go and reach into the extravascular space. By locating in the extravascular space, if they exert the oncotic pressure, the further intravascular fluid will go into the extravascular space. So initial period you need to transfuse only with crystalloids. Once the patient recovers and the leaky junctions get stopped, then again you have to give the colloids, but no colloids, no hypotonic fluids for initial resuscitation. And in the meanwhile you search for the cause. So before understanding the resuscitation and how to monitor the resuscitation, what are the various lines of response, and what is the management algorithm for the other shock, you need to understand two terminologies with regard to shock. One is the central venous pressure and another one is the pulmonary capillary wedge pressure. Central venous pressure is nothing but the pressure that is the right atrial pressure or a superior vena cava pressure that is measured. So it can be measured either with the help of a manometer, that is a pressure system, or a transducer system which has an electrical way of measuring. So what you do is you ask the patient to lie down, you measure the central venous pressure with the help of at the level of the heart, right? So for this, a central venous line should be inserted and it should be connected to the appropriate manometric tubings to measure it. So the normal value of central venous pressure is around 0 to 8 millimeters of mercury. What does it reflect? So the central venous pressure reflects the preload status. That is, we already discussed the jugular venous pressure, preload status, like how much amount of venous return to the heart is happening, and how the heart is tackling that venous return by ejecting it to the by making it into a cardiac output. That is what the central venous pressure detects. So it can identify and it can differentiate between a hypovolemic shock from a cardiogenic shock. Hypovolemic shock, what will happen? Preload will be low because there is low intravascular volume. So CVP will be low in hypovolemic shock. Whereas in cardiogenic shock, what will happen? The heart is not able to pump because of cardiac failure. So the preload will be high. There where the CVP will be high in cardiogenic shock. But how to differentiate between a cardiogenic from an obstructive shock? So cardiogenic shock is primary heart failure. Obstructive shock is something that is obstructing the heart to function properly. That we have found the examples of obstructive shock. The causes: pneumothorax or tension pneumothorax, pericardial tamponade, restrictive cardiomyopathy, and finally pulmonary thromboembolism. What you'll do is they have a way of differentiating them by using a pulmonary capillary wedge pressure. You introduce the Swan-Ganz catheter. Swan-Ganz catheter is a catheter. All these will be done by intervention procedures under fluoroscopic guidance. So we introduce the catheter, you go through the right atrium, right ventricle, and enter into the pulmonary artery. And pulmonary artery, that is the lung. So you at the site of entry into the lung, you inflate the balloon and you measure the pressure there. So what it measures? It measures the stagnant blood column that is happening here. So there should not be any mitral stenosis to measure the left ventricle. So this pressure reflects the left ventricular end diastolic pressure. That means, in simple terms, left ventricular function will be better found with pulmonary capillary wedge pressure. Its normal value is around 2 to 15 millimeters of mercury, right? So what happens when the pulmonary capillary wedge pressure is high or low? So it can differentiate between the cardiogenic from a non-cardiogenic shock, from an obstructive shock. In cardiogenic shock, the heart cannot pump, so more amount of stagnant blood will be there. So what happens? The pulmonary capillary wedge pressure will rise. Whereas in thromboembolism or obstructive shock, the pulmonary capillary wedge pressure will become low. So how do you monitor the response to resuscitation in a patient with shock? You take hypovolemic shock as an example. What happens? You start resuscitation and identification or diagnosis and clinical examination by hand in hand. So initially, when the patient comes to you to the trauma table or to the emergency department, you immediately introduce two or large IV cannula. So IV cannula, shorter the length, more the blood flow. Larger the bore, more the blood flow. Large bore, short IV cannula. So you can transfuse large amount of fluid in a minute. So initially you give 1.5 liter of fluid. What fluid? NS or RL, rapidly within 45 minutes. During the transfusion, during the infusion, you should assess the parameters, that is pulse rate, blood pressure, and central venous pressure, whether they are going into normalcy, whether they are reverting back, whether the tachycardia is coming down, whether the blood pressure has been maintaining or improving. CVP has raised in case of hypovolemic shock. They are called responders. Transient responders, initially after a period of fluid resuscitation, they will respond, but ongoing bleeding will be happening. So after 20 minutes, they cannot maintain this clinical parameters. They will again go back to tachycardia and hypotension. They are called transient responders. Whereas non-responders, that means we are intervening that patient at the late stage, that is the patient has developed into a moribund or a decompensated state of shock. So in such cases, there will not be any response. So based on this initial dynamic fluid response, we are classifying the patient as responders, transient responders, and non-responders. Responders, you can continue them with the maintenance fluid. Transient non-responders, you need to search the cause for shock probably bleeding. For such patients, it requires surgical control or any method of hemostasis achievement. Non-responders, you need to escalate the treatment. So the next in line is going to be inotropic supports. Inotropic supports are nothing but these are the drugs that will increase the cardiac output, right? Like dobutamine. So in cardiogenic shock, the heart is not able to pump. So if you give dobutamine, IV dobutamine, the heart will be pumping better, thereby increasing the cardiac output, and the patient recovers from the shock. And then peripheral vasodilated status like septic shock. In such cases, you need to give a noradrenaline. Noradrenaline is a intense vasoconstrictor, peripheral vasoconstrictor. So that will be the treatment of choice for septic shock. Whereas even then it's not responding, you have the other drug that is called vasopressin. So you just remember, septic shock, noradrenaline is the fluid of choice. For cardiogenic shock, dobutamine is the drug of choice. So how to monitor the shock? We monitor with central venous blood pressure, urine output. These are the basic parameters, as well as pulse and blood pressure. Along with that, pulse oximetry, ECG can be taken in case of cardiogenic shocks. And additional modalities we discussed in central venous blood pressure, invasive blood pressure like pulmonary capillary blood pressure or arterial blood pressure. Cardiac output can be used, and base deficit and serum lactate we already discussed. These can be obtained by arterial blood gas analysis, ABG. So serum lactate should reduce when the patient is responding. When the patient, even after giving treatment, when the lactate is not coming down and the base deficit is not coming down, that the patient is in a state of cellular hypoxia and resultant acidosis. Such patients need change of treatment. So what are the pitfalls in analyzing capillary refill, tachycardia and blood pressure? Tachycardia is the earliest sign of any shock, right? Agreed. But what if the patient is on beta blocker? What if the patient is an athlete where the baseline heart rate is around 40 to 50? In such cases, even 70 is considered alarming. Okay, generally tachycardia is heart rate more than 100. So you cannot fix the criteria for all these things, and it varies with patient to patient. Okay, so with patients in beta blockers, tachycardia cannot be identified, will be masked by the beta blocker. Blood pressure is usually the late event in the shock. So blood pressure is normal, patient is not in shock. Probably the patient might be in compensated shock or mild shock. Children usually will not have any hypotension when before presenting it as a late sign. So blood pressure cannot be taken as a proper parameter. Heart rate cannot be taken as a proper parameter. And capillary refill. Capillary refill means you just pinch, there will be blanching, and after removing that pressure, there will be capillary refilling. Generally this capillary refilling, do you think it will be happening in a patient with shock? No, or a delayed capillary refilling will be happening because the skin vessels will be vasoconstricted. So whenever you press or not, there is not going to be any change, and the capillary refill is going to be late refill in all shock, whereas it is brisk in septic shock or distributive shock. Why? Because in distributive shock, what happens, there will be peripheral vasodilatation and increased tissue, increased pooling of blood in the peripheries. So these peripheries will be warm, and brisk capillary refill will be found in distributive shock, but not in hypovolemic or cardiogenic shock. So these are the pitfalls in assessing and using it as a monitoring for any patients with shock. The other systemic perfusion we have identified, we already discussed base deficit, serum lactate, mixed venous oxygen saturation. I already described the oxygen saturation in the venous blood will normally around 50 to 70%. When it is less than 50%, more oxygen is consumed by the cell, that is seen in hypovolemic and cardiogenic shock. When the oxygen saturation is more than 70%, it is seen in distributive shock because oxygen is underutilized because of cellular hypoperfusion there. So these are the indicators to identify systemic perfusion. Specific organ perfusion, we have high-end technologies like infrared spectrometry, mucosal pH analysis. All these can be used for monitoring shock or local tissue perfusion. So with this we have described about the resuscitation, response and monitoring, how to monitor the shock. So how to treat the hypovolemic shock? Documented hypovolemic shock, tachycardia, hypotension, decreased central venous pressure. Immediately you give IV fluids. Patient you have to find as responders, transient or non-responders. Transient responders and non-responders you have to give inotropic drugs like dopamine or adrenaline or noradrenaline. Still unstable, you need to give proper fluid management according to the CVP. So the goal is to maintain BP, maintain urine output. So what is the normal urine output that is required? 30 ml per hour, and CVP should be maintained more than 8, that is normalcy. So only then the hypovolemic shock will be treated. So other type of hypovolemic shock is hemorrhagic shock. Hemorrhagic shock, for any hemorrhagic shock, first treatment is to control the hemorrhage, achieve the hemostasis. We will describe that in the next video, right? So the primary goal is to stop the bleeding. So whatever if you have to replace, the best replacement for blood is blood. So blood has to be replaced with blood. So the goal is to maintain the mean arterial pressure. So when there is associated brain injury, the mean arterial pressure should be kept higher. When there is no associated brain injury, the mean arterial pressure can be maintained at the lower end. So if it is not responding to blood, not responding to inotrope, or not responding to IV fluids, you can start with noradrenaline and vasopressin, whichever is feasible for the patient. And our final treatment is going to be surgical control or any mode of hemostasis to control the exsanguinating hemorrhage. And moving on to septic shock. Septic shock is nothing but documented infection in a state of shock. So in such cases, you need to start antibiotics within 1 hour. That is the most important measurement. And the goal, you need to maintain the central venous pressure, you need to maintain the mean arterial pressure, you need to maintain the mixed venous oxygen saturation. I already told the oxygen will be underutilized, so mixed venous oxygen saturation should be more than 70% in a patient with septic shock. You should not try to bring the mixed venous oxygen saturation to 50 to 70%. It should always be maintained more than 70%. After that, the aim is to treat the sepsis with antibiotics and infection control, either in the form of surgery or whatever may be the cause for septic shock. Then you proper IV fluid resuscitation and bringing down the acidosis levels to normalcy. So with this we discuss with some MCQs. What is the best guide for management of resuscitation in shock? The best guide will always be central venous pressure. Okay, if urine output is given in the option, that can be used, but the question should be best clinical parameter. Which of the following can differentiate cardiogenic shock from obstructive shock? We discussed this. So cardiogenic from obstructive, primary cardiac problem or else something that is around the heart that is causing the cardiac problem. To find that, you need to measure the left ventricular function. So left ventricular function can be better identified with pulmonary capillary wedge pressure. Which of the following can differentiate cardiogenic from hypovolemic shock? To know that, you need to know the preload status. So preload can be better differentiated or better identified by the central venous pressure, as we discussed in the central venous pressure slide. Goals for managing septic shock is all except, ideally you should control the infection, you should correct acidosis, maintain the CVP, but the mixed venous oxygen saturation should be more than 70% and not in the normal range. So with this I conclude this. In the next video we will discuss about the hemorrhage and blood transfusion.